I think with the numbers we have, we can start. So welcome once again. We're hoping this meeting with enough knowledge to help in management of our neonatal cases. And I'll humbly ask that we all take a pen and a paper and at least jot down something, because I believe our resource personnel are going to give us a lot of information. We'll start with the purpose of the discussion or the overview of the conference, and it's going to be given by Dr. Abnonya Koba-Fuiwa. So at this juncture, I'll invite her to please take over for the overview of the conference. Dr. Abnonya, over to you.
Good afternoon, senior colleagues and colleagues. You're welcome to this year's first perinatal conference. Hope Exchange Medical Center serves as a referral center for cases within the Kwadaso Municipal and Kumasi Metropolis, and then also the region as a whole, and in few cases beyond the region. So as at March 2024, we had about 41.4% of all admissions from referrals. All admissions from the NICU from referrals. And given this information, we think it's appropriate to organize such conferences, which will help to update ourselves on current practices and to discuss issues and challenges with regards to referrals. We hope that this conference will add on what we already know, and hopefully by the end of this conference, we'll be able to gain clarity as to whether or not to treat malaria after transfusion of the newborns and how exactly to treat, since right now we don't have the artesunate amodiaquine. You are welcome once again, and we hope you enjoy this conference. Thank you.
Thank you very much, Dr. Abena. Thank you very, very much. So this juncture, we're going to introduce our speakers for this conference. And we are honored to have two great resource personnel who will be educating us during this period. We have in our midst Mrs. Barikisu Adamu, and then Dr. Epie Free. These are going to be our key resource personnel. For the first presentation, we're going to take a presentation from Mrs. Barikisu Adamu, who happens to be a neonatal nurse. She has a lot of experience in the neonatal department. She's currently the in charge for the NICU at Hope Exchange. Mrs. Barikisu Adamu Nyani, can you please take over the floor? Thank you.
Hello, good afternoon.
Good afternoon.
Good afternoon.
I'm Adamu Barikisu, a neonatal nurse, and I'll be talking about the vitals of the newborn, knowing the vitals we'll be having. So I'll start showing my screen. Kindly let me know if my screen pops up. Please, is my screen visible?
Yes, it's visible.
Yes.
So this presentation will cover the definition, the purpose, the key vital signs of the neonate, how to assess the various vital signs, and then conclusion and the references. So when we talk of vital signs or cardinal signs, They are the indicators that we use to check the function of the newborn. And it differs with the age, the gender, the time, medications, and environment. Whether cold or hot, the environment can also detect the vital signs of the newborn. And vital signs is a major indicator of the baby's overall health being. So why do we take vital signs? One, we take vital signs to detect the normal body function and also to determine the response to treatment, whether the baby is improving or rather deteriorating. The vital signs will be a major key. These are some of the vital signs that are being managed in the newborn, that are typically monitored in the newborn. We have the respirations. Sorry. We have the respiration, the heart rate, the temperature, the oxygen saturations, the blood pressure, random blood sugar, the length, height, head circumference, and etc. But I'll be talking much about the respiration, the heart rate, the temperature, and the oxygen saturation. The oxygen saturation. So these are the reference range for the vital signs of the newborn. The temperature is 36.5 to 37.5. The heart rate, which is the same as the pulse rate, is 100 to 160 beats per minute, but this, I think I had 120 to 160 beats per minute. I know we are all conversant with the 100 to the 160 beats. Respirations, 40 to 60 breath per minute. The blood pressure, 60 over 40 millimeter of mercury, and oxygen saturation of 95 to 100%. We'll do an in-depth explanation on this. So we go to how to assess the baby's respiratory rate. The most reliable way to measure a newborn breathing rate is to count the number of breaths for a full 1 minute. We know that unlike the adults where you count the respiration for 30 seconds and multiply it by 2. In
Excuse
neonates,
me, madam.
please come again.
Your slides are not moving.
The slides are not most of the game.
Yeah, I'm just explaining something.
No, we're still on the first page.
Really. Please hold on. I'll come.
Please kindly bear with us as we sort the presentation out. Our Zoom can only accommodate 100 participants. So once it hits the 100, you cannot allow anyone else to join. So you can join live on YouTube. Thank you. All right, we're so sorry for the interruption in the presentation. We're still trying to sort it out. But in the interim, we would invite our second speaker, Dr. Ikia Efriye, who is a neonatologist at Komfo Teaching Hospital and is also a fellow of the Ghana College. Dr. Ikia Efriye, can you please take over?
Good afternoon, everyone.
Good
Good
afternoon.
afternoon. Good afternoon, doctor.
Please, I hope you are all doing well.
Very well, sir.
Yes, please.
Thank you very much for this opportunity. I'll say thank you very much to the organizers for organizing such an educative program. We are very grateful for inviting us on board. This afternoon, we want to share some few things. Today is World Malaria Day. So we are going to talk a little bit about malaria in the newborn, that's congenital malaria. Please give me some few minutes. Let me share my slides and then we can continue. One. Please, I hope you can see my slides.
Yes, please, we can.
Yes,
All right. Thank you very much. So as I said, today marks World Malaria Day. And I think it's very appropriate for us to talk about malaria in the newborn. In fact, it's a subject that it's not something that we frequently talk about. But since today is World Malaria Day, I think it's apt that we take some time to talk about malaria in children. So without much ado, I'll just go straight to the points. So before we start everything, let's start with a pre-test. So let's test our knowledge. I believe we've had lunch, so this is just like a dessert. Let's all have the dessert, munch over these 4 minutes. Please, can we mute our mics whilst we munch on these 4 simple questions? This is just a pre-test. Please test your knowledge. Just get some sheet of paper, jot down your answers. It's true or false. So when you either it's true or it's false, it's very, very easy. So this afternoon, let's just take some few seconds, 1 or 2 minutes, go through, finish it up, and then we can continue with our presentation. So please, let's box on. The first question reads, congenital malaria is highly prevalent in malaria endemic areas, and your answer will either be true or false. And the second one reads, congenital malaria leads to a high parasitemia in neonates. Okay, you either answer true or false. Then let's go to our next one. Fever, anemia, splenomegaly are some of the features of congenital malaria in neonates. Again, the answer is true or false. You just choose one. Then the fourth one reads that congenital malaria is easily diagnosed with blood film staining. Again, it's true or false. I'm a very generous examiner, so I've given you time, munch over it a little bit, and then we can go on to our presentation for the afternoon. All right, I guess we are all done, so we can go on. Don't worry, we'll come back to the pretest. I believe you all have 100, and we'll give you toffees via Zoom. So let's go on, don't worry, we'll come back to the pretest and we'll answer them together. Now, this will be our outline. We are looking at the overview of malaria. As I said, today is World Malaria Day. So we have to give malaria some attention. In fact, malaria has been giving us a lot of attention. So today is a day we have to pay malaria back. So we just look at a little overview of malaria. We look at the epidemiology. Then we'll look at a case study. Then we'll come back and look at the mode of transmission, the clinical features that you have to look out for in the neonates, investigations, the management, some complications. And then one last thing we'll focus on will be the prevention aspect, prevention of malaria. So that's basically what we are going to do this afternoon. I'm not going to take much of your time. We are going to go through this quite quickly. So now, when we talk about malaria, I believe malaria is a household word. In Ghana, I believe everyone, if you say malaria, it's not a word that somebody will say that, hey, what is it that you're talking about? What are you saying? This is a big word. No, it's a street word. Wherever you meet people, in the market, at church, in school, wherever, when people are not able to come to it, they say, oh, I had malaria. Oh, when somebody is not feeling so, oh, I had malaria. I mean, malaria is a household word, but where did this word originate from? We realize that malaria is derived from an Italian word, which is like a combination of two words, mal and area, which is translated bad odor. So when we say malaria, oh, I had malaria, all that we are saying is that there is some bad odor somewhere. I guess, in fact, I did not really read into the very origin of the word, but I guess you know that malaria is usually found in where there's stagnant water, there's this, and those ones sometimes generate bad odor. And I believe that's the reason why they first gave malaria the name malaria, because of where you usually will find the mosquitoes, and that's where the transmission of malaria is maximal. So it's translated bad odor. Now, malaria is a very ancient disease. In fact, malaria is older than all of us. It's a very ancient disease. And in fact, when you look into literature, the first incident of malaria dates back to the about 1500 BC, wherein you know that civilization invariably, according to historians, was like from Egypt. So during those the times that Egypt was Egypt and was leading civilization in this world, it was documented in their archives or in their books. They call it the papyrus. Yes, it's documented there, the disease malaria. So we realize that malaria is a very ancient disease. It outdates all of us. So we have to show malaria a lot of respect. Malaria is not a small boy disease at all. It is an ancient disease. Now, although it's an ancient disease, and it was quite worldwide, but we realized that in Europe, in most parts of the Americas, and some parts of Asia, they've been able to eradicate malaria. So although malaria is an ancient disease and it was quite widespread, when you look into history, it was quite widespread. In Europe, there had been instances where there was malaria. In Asia, in the Americas, malaria was present. But we realized that some parts of Europe, I mean, almost the whole of Europe, most parts of Americas, and then parts of Asia, malaria has been eradicated. But malaria remains an important cause of morbidity and mortality in the tropics, where we find ourselves, Africa and some parts of Asia. Malaria is a very important cause of morbidity and mortality. Now, we say malaria, when I can't go to work, malaria. When today I feel lazy, I don't want to sweep my house, I say malaria. Everything we say malaria. What exactly is malaria? So malaria is a life-threatening disease and is caused by Plasmodium parasites, which are transmitted by the bite of a female Anopheles mosquito. The malaria is an acute disease and is caused by Plasmodium species. And usually these Plasmodium species are transmitted by the bite of the female Anopheles mosquito. We say that the female Anopheles mosquito, it doesn't mean to cause us a lot of harm. It comes about romantically to kiss you. And when it gives you that kiss, it can result in chills. That's why you start having the chills, the fever, and everything. And as I said, this mosquito, it does not mean so much harm. Have you noticed the time they come around? In the evenings, they are very, very romantic. They are coming for a date with you. So they come find you with your legs bare, your hands bare. They give you a kiss, like we are seeing here, giving the host a beautiful kiss. It's just been a romantic insect. And when it gives you this kiss, it can land you in a lot of trouble. That is the Anopheles mosquito. Now, let's talk about a little bit of history. As I said, today is World Malaria Day. So we have to delve a little bit into this whole malaria thing, how it evolved to get to the point where it is today. Now, prior to the 1980s, although they described malaria in terms of the features and how it comes out and all that, they did not really know what the real cause of the disease was. So it was Charles Laveran who first observed the malaria parasite in red blood cells. That was in around 1880. He's the first one to have observed that these malaria parasites, they come and attack red blood cells, and that is when we start having the disease. And then Roland Ross in 1897 was able to describe the life cycle of the parasite in the human body and also in the vector, that is the mosquito. Then the fact that the mosquitoes are responsible for transmitting malaria was proved by Bignami and Bastianelli in 1898. In fact, their great work in malaria was rewarded by Nobel Prizes. And so this afternoon, I'll advocate that all of us, let us try and discover more. I mean, there are so many diseases that affect us. Malaria is one of them. And we are not through with malaria yet because we are still yet to eradicate malaria in our part of the world. Let's do something so that our names will be in the Nobel record, so that we don't focus so much on the cookathon and the singathon, and malaria-thon is there. Let us focus on it because these ones, they did a lot of work and they were able to get Nobel Prizes for them. So as for malaria-thon, when you do any work, me, myself, I promise you that I will give you the reward. So please, let us get to work. All right, now let's talk a little bit about the epidemiology. So malaria, as I said, is like our big brother, has been around for a long time. In fact, grandpa, we should call it grandpa malaria and salute malaria because malaria has been there for a long time. But this malaria is not a joke. Although, as I said, it's a household name. We keep mentioning malaria every day, now and then. Oh, everything malaria. But malaria is not, sorry. So, but malaria is not a joke. Sorry, I messed up my slides. I hope you can see my slides.
Yes,
please.
yes, we can.
Yes, so then we can continue. Yes, so malaria is not a joke at all because according to WHO, in 2022, approximately 250 million people globally had malaria. About 220 million people had malaria. Out of this, about 600,000 of them died. So as I said, malaria is our grandpa, but malaria needs to be saluted because it does a lot of havoc to human life. About 600,000 people died of malaria globally. Now, the sad aspect of this is that it's not like there's a global, well-distributed malaria cases. No, Africa bears about 94% of these malaria cases. 94%. And sadly, about 95% of the deaths from malaria occurs in Africa. Oh, malaria is not a joke at all. Although malaria is grandfather disease, malaria is still very potent. Don't ever underestimate malaria, thinking that, oh, malaria been around for so long. Even the small child knows malaria. Malaria is not a joke at all. Now, Children under 5 years bears about 80% of cases of malaria worldwide. So although malaria is a very ancient disease, and we can even call it grandpa malaria, when malaria comes and is infecting, it infects young children under 5 years, and it causes a lot of havoc, causes a lot of death in these children. Now, among pregnant women, malaria prevalence in Ghana reduced from about 60% in the 90s to about 5 to 20% in 2018 in the first zones of Ghana, which is a very good thing. But we'll throw more light on this aspect when we talk about pregnancy and malaria, and also neonates and malaria. Because when we talk about congenital malaria, our focus is from the mother. We know that in neonates, the mother cannot just be separated from the neonate. So we'll throw more light on it as we go by. But have this at the back of your mind that malaria is not a joke at all. When we look at these statistics, we realize that malaria is not something we should just joke about. Now, let's relax a little bit and look at a case study. A case study. So we have this nice baby boy born with a weight of 2.9 kilograms. He was delivered by cesarean section to a 26-year-old mother, and the delivery was due to antepartum hemorrhage in the mother at 39 weeks of gestation. Now, when the baby was born, he developed respiratory distress and required CPAP, continuous positive airway pressure, for about 60 hours of life. Now, on day 3, in fact, when he developed the respiratory distress, we can say that by cesarean section, transient keeping of the newborn could have been one reason why, although he was on oxygen for quite a while anyway. But eventually, after about 60 hours, that's about 2 days and some hours, we were able to wean the child off oxygen. Now, he developed a fever and jaundice on day 3 of life. And because of this, the baby required phototherapy for about 48 hours. Now, we did a further examination because we thought that there wasn't really any risk factor for sepsis, because the mother, there was no problem. Mother did not complain of any fever, any UTI. The only thing was that there was antepartum hemorrhage, for which a cesarean section was done. Now, further examination showed that he had a liver of 5 centimeters and the spleen of 3 centimeters. Now, we did some investigations, at least our preliminary investigations showed that the hemoglobin levels was 9.2 gram per deciliter. The platelet was 89 times 10 to the power 9, and the white blood cell count was 6.5. In fact, the white blood cell count was within normal rate, but the platelet was slightly reduced, and the hemoglobin levels were also slightly reduced. So we were wondering, what could be the cause of this child's presentation? So please, let us all give our answers. What do you think is going on with this baby? Now, let's say it's still 3 days old, let's say 3 to about 5 days old, and we are getting all this in the baby. What would be your possible diagnosis for this child? Let's ponder over it, try to get our differential diagnosis whilst we go on with our presentation, because we'll revisit it. We'll revisit our case study. So now let us proceed. Now, what is congenital malaria? What is congenital malaria? we've talked about malaria and we know what malaria is. And for every one of us as adults, you have experienced malaria at one point in time or the other. I mean, I'm yet to meet a Ghanaian adult who doesn't know malaria, has never had malaria. And in fact, if you meet somebody like that, I think you should try and lobby with the person to transfuse some of the blood to you, because that person has a very strong immunity. So malaria is very common in our setting. But when we talk about congenital malaria, it's not something that we usually talk about. And we will throw more light on it. I think that it is a good opportunity for all of us to throw a little bit more light on congenital malaria and malaria in the neonates or in the neonatal period. Now, congenital malaria is defined as the presence of the ancestral forms of parasites in the peripheral blood of a baby within 7 days of life, and it can be with or without clinical features. So all that we are saying is that there is a presence of parasites in the blood of the neonate. However, this neonate is within the first 7 days of life, and the neonate may or may not have clinical features suggestive of disease. So you can have a very stable neonate. When you check, there can still be parasites in the peripheral blood. So that is congenital malaria. Now, when we talk about neonatal malaria, that is where there is a presence of parasitemia with some clinical features present in the first 28 days of life. In the first 28 days of life. So from day 7 or from day 8 up to day 28, if a baby comes, has some features, and you take the blood and you realize that there is parasitemia in the blood film, and the baby is having symptoms, then you can say that the baby has neonatal malaria. So I guess the difference is quite clear. In the very first 7 days, with or without symptoms, if there is parasitemia, that is parasites in the blood, we can say that the baby has congenital malaria. Neonatal malaria is where there are parasites in the blood, but the baby is from day 8 to day 28. So he has passed the 7-day period. Now, congenital malaria is not so common. It's not so common. And I say it with a little bit of caution because you see, where I work, I'm at the referral center. It's possible that at the peripheries, we may see a lot of malaria. Maybe because I'm at the referral center, most of the time, the babies, by the time the babies get there, they might have been treated already. So I may not be able to isolate parasite on blood film. So I say it with a lot of caution. But by and large, after searching through literature, we realize that it's not so common. Having said that, there are some studies also. So we'll come to all these, a little bit of controversies and all that. We'll come to all this as we go on with the presentation. But we say that, you see, babies born to mothers who are immune, usually they have a very low chance of having congenital malaria. But who are these immune mothers? If I say that a mother is immune to malaria, who is a mother who is immune to malaria? A mother who lives in an endemic area, like you and I. We live in this malaria endemic area. And because of that, we have had malaria several times. And because of that, we have had antibodies to malaria parasites. So we are immune mothers. Like if you give birth, you are an immune mother because you live in a malaria endemic area. Now, I believe that when we talk about the epidemiology, I talked about the fact that in parts of in Europe, in parts of the Americas, in parts of Asia, they've been able to eradicate malaria. So in those areas, if there's a mother living there, and by some means, maybe by travel, she comes to a malaria endemic area, picks up a parasite, goes back, she is a non-immune mother because where she resides, there isn't malaria. I mean, malaria has been eradicated. So when she gets malaria, it's severer because she doesn't have a buildup of antibodies. So that is a non-immune mother. So we realize that congenital malaria may occur in either of these mothers, but in babies born to mothers who are immune to malaria, the chance of having congenital malaria is about 0.3%. However, if a baby is born to a non-immune mother who has been infected with malaria parasites, the chance of having malaria is higher, about 7.4%. Now, usually, babies who have maternal parasitemia, sorry, babies who have congenital malaria, usually they have maternal parasitemia. The mothers have parasitemia. The mothers have parasitemia. And when I say that, I believe it follows because usually they get the malaria parasites from the mothers. So the mother usually has the parasite in the system. The mother usually have the parasite in the system and then transmits it to the baby. We'll look at the mechanism of the transmission as we go on. Now, malaria, usually these, for congenital malaria, you can isolate the parasite, sometimes even from the cord blood. From the cord blood, you can isolate these parasites, or from the peripheral blood of the baby. So either from the cord blood at birth or from the peripheral blood of the baby, you'll be able to isolate the parasites. Now, let's focus on congenital malaria and talk about its epidemiology. Now, globally, it's estimated that congenital malaria's prevalence is around 40.4%. Now, in Africa, where malaria is endemic, the prevalence is a little low, that is 39.5%. Now, outside Africa, where even some places they've been able to completely eradicate malaria, it's slightly high, that's about 56.3%. Now, when I talk about neonatal malaria, globally, the prevalence is around 12%, and in Africa, it's about 12.1%. And outside Africa, about 12.5%. Now, I believe that with these statistics, the question will be, why is it that we're having more congenital malaria than neonatal malaria? One of the reasons is that, remember in our definition for congenital malaria, we said that whenever you get the parasites in the blood, with or without clinical features. So in a population, all the babies, you just test, find out whether there is malaria in the blood within the first 7 days of life. You can even use cord blood. This will be a good study anyway. You can even use cord blood. Check whether there is malaria parasites. And that is what is giving this prevalence. But for neonatal malaria, there should be malaria parasites plus clinical features. And that is why the prevalence is a little low. Because you will not check unless the baby presents with clinical features that is suggestive of malaria. All right, so these are the statistics, the glaring figures. So we shouldn't joke. In fact, when co-patient contacted me and talked about congenital malaria, I said, oh, you see, congenital malaria is so common. How many of them have I seen? But when I looked through literature, then I realized that obi nima obi chire. Every day you have to learn something new. Congenital malaria exists, so we shouldn't joke with it. All right. Now, we have talked about these malaria-causing organisms. That's the Plasmodium, Plasmodium, Plasmodium. For Plasmodium, we have 4 main species. Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae. Now, Plasmodium falciparum and vivax are the 2 main species that have been identified as causative organisms for congenital malaria. This I'm talking about on a global scale. On the global scale. In Ghana here, studies have always isolated Plasmodium falciparum as the culprit. So in Ghana here, almost all the studies that I looked at, Plasmodium falciparum was the one causing the congenital malaria. And remember, and it follows because, in fact, Plasmodium falciparum is the most prevalent species in Ghana. When you talk about having malaria, Plasmodium falciparum is the most prevalent. Vivax is there, all right. Ovale is there, all right. But falciparum, it remains the most prevalent. And falciparum is also the most deadly. The most deadly. It causes a lot of morbidity and mortality. In this case, in our neonates, in the pregnant woman, in everyone, falciparum is the most notorious for morbidity and mortality. So these are the 4 main species that you should look out for. But in Ghana here, as I said, the Plasmodium falciparum is the one which is the top when it talks about prevalence of congenital malaria. Falciparum is on top. Now, what's the mode of transmission of this disease? We have 2 main modes of transmission. We have the horizontal and the vertical. The horizontal one is where you get a bite. As I said, this female Anopheles mosquito is a romantic friend, comes in the evenings, comes on a date to bite you, like it's in the business right now, as you can see on the screen. So when there is transmission via the vector, we call that the horizontal transmission. So you bite Mr. A, gets parasite, gets red blood cells, multiplies these Plasmodium species, goes to Madam B, then goes to Madam B's child, then goes to Madam B's child's friend, then goes and goes and goes. And in every instant, we deposit these malaria parasites. So that is the horizontal transmission, where there's the vector mode of transmission of the malaria parasites or the Plasmodium species. Then another important thing is that it can be transmitted through blood transfusion. It can be transmitted through blood transfusion. Remember that the parasite can live in stored blood for about 14 days, although the stored blood may be at a temperature of -4 or below. So this malaria parasite, as I said, this Plasmodium species, they really mean business. They really mean business. And when I saw this, I was not surprised that even in Europe, there was malaria, because it doesn't respect temperature. Although, yes, mosquitoes, they enjoy this, our weather. That one is true. I will not come here and say that they do. They do enjoy the weather, and they like the environment. But then having cold temperature alone will not stop Plasmodium from infecting you. So that's what we all have to have at the back of our minds. And one other thing I didn't add is that malaria can be transmitted through needles, needle prick. It can be transmitted through needles, needle prick. So if a person has malaria parasite in the blood and you use a needle on that individual and the needle pricks you, you can have malaria. It's not only HIV and hepatitis that is transmitted through needle pricks. Malaria parasites can also be transmitted through needle pricks. So have that at the back of your mind. Then the next mode of transmission is the vertical transmission. The vertical transmission. When we talk about congenital malaria, most of the transmission is vertical transmission of malaria. Now, vertical transmission of malaria is more common in areas of low prevalence of malaria. So all that I mean to say is that when we talk about vertical transmission, that is from mother to baby in utero, it is more common in malaria non-endemic areas. Non-endemic areas. And I believe by now, you all know why I'm saying this. It's because these women who live in non-endemic areas have got low levels of anti-malaria specific immunity. They have low levels of anti-malaria specific immunities. And because they have low levels of immunities, the species easily proliferate, infect the placenta, and can be transmitted to the baby. Now, you will say that, but here in the endemic areas where people get more malaria, why are we saying all this? Truly, in endemic areas too, there can be vertical transmission. It's just that it's just lower. We are not saying it doesn't occur. It is lower in these endemic areas than in non-endemic areas. Now, the baby in utero is protected from malaria due to a number of reasons. Is due, so when we talk about the statistics, one was 0.3 in the endemic, then 7.4 in the non-endemic. So realize that even there, the transmission of the malaria to the fetus is quite low. So you ask yourself, why? Because actual malaria parasites is quite common in our setting. Why is it that these babies are protected? It's all because the placenta forms an effective barrier to infected red blood cells. So when the red blood cell is infected, the placenta serves as a barrier and does not allow those infected red blood cells to get into the baby's circulation. Then the placenta also allows passive transfer of the maternal antibodies to the baby. As we said, as we all know, you see, when there is infection, there are antibody production. So the placenta allows the antibodies that have been formed in the mother to be transferred to the baby. To be transferred to the baby. And then it also the fetal hemoglobin is also very protective towards malaria. It can withstand the malaria parasites. The fetal hemoglobin can withstand the malaria parasite. That's why these neonates have a low prevalence of malaria. And then, in fact, some of them even have the malaria parasite, but they do not exhibit any clinical features. And these are some of the reasons why. Now, for the exact mechanism of congenital malaria, scientists are not 100% sure. It has been postulated that the congenital malaria will be from placental transfer. And some people have also postulated that it can be peripartum. That is when the baby is coming down through the birth canal. We know that there's mixture of blood and so many other things. There's exposure during the birthing process. So people have said that it's the exposure during the birthing process that exposes these neonates to malaria parasites causing malaria, congenital malaria. These schools of thought are because you see the placenta serves as an effective barrier. That's why people are like, this shouldn't be the mode or the mechanism by which the babies get the malaria. But having said that, usually congenital malaria occurs in mothers who have low immunity for whatever reason. Low immunity. Remember that pregnancy itself puts the mother in a low immunity state. So first and foremost is the pregnancy. Then second, there can be other conditions that can put the mother in an immune state. HIV is one of them. And then some studies show that mothers who had HIV had babies who had more congenital malaria. So whenever the mother's immunity is compromised, there can be more congenital malaria. Another thing is that anything that affects the placenta's integrity. So we know that there are conditions that can affect the integrity of the placenta. Cause placenta insufficiency, cause infection of the placenta. Chorioamnionitis is one of them. So if the placenta itself is not in a very good state, then it cannot form an effective barrier against the transmission of Plasmodium species. So these are the mechanisms that have been entertained in literature when you talk about congenital malaria. Now, we are going on to talk about the clinical features. Remember that we said that clinical features regarding congenital malaria may or may not be present. When you talk about congenital malaria, strictly according to the definition, whenever you see malaria parasites on the peripheral blood, or it can even be the cord blood, then there's congenital malaria. The baby may be asymptomatic or not, or may have symptoms. So there may be symptoms, there may not be any symptoms. That is congenital malaria for you. Now, usually, the babies who even have symptoms, the symptoms occur quite late. So the symptoms may occur from about day 10 to day 30 of life. That is where the symptoms usually occur. We don't know whether it's just because of the life cycle of the Plasmodium species. You know that they have incubation period and all that. You know, we don't know that for sure. Neither do we know whether it's mainly because maternal antibodies, because they are in utero, maternal antibodies sort of covers them. When they come out now, gradually the maternal antibodies are giving way, and so now they start exhibiting the features of the malaria parasites. All these are schools of thought and that we can entertain. So some of them may present with fever, They may present with poor feeding. They may present with lethargy. They may present with pallor. They may present with jaundice, irritability, drowsiness, hepatosplenomegaly, sometimes even thrombocytopenia, and sometimes even respiratory distress. So they can present in a very, very varied and non-specific way. Very, very varied and non-specific way. And now, you know, these newborn symptoms can go for sepsis. Very, very common. So all these put together makes it quite difficult for you to just say that, oh, this is congenital malaria, because it can go for sepsis. Please, I hope you can still hear me. The slides are running.
Yes, please.
All right, thank you.
Yes, please.
Thank you. Continue then. Yeah, so these clinical features are very non-specific. It can go for a myriad of neonatal conditions. It can go for a myriad. It can even go for severe jaundice in a baby. It can go for sepsis. It can go for, so meningitis. It can go for, so you need a very, very, a very, very, you need to convince yourself that you have to test for malaria as well, or else you may easily miss congenital malaria in the new or neonatal malaria, either of them, depending on the time the baby presented. Now, how would you investigate a baby who comes in and you suspect congenital malaria? So you can do the Giemsa staining. That is the thick and the thin films. The thick film will help you to identify that there are malaria parasite, the Plasmodium species. There are some in the blood. And the thin films will help you to identify the particular species. We said that there are 4 main species in the country. And so it will help you to identify which one you are dealing with. Then you can have the antigen detection based test. An example is the rapid diagnostic test. And we all know RDT for malaria, we all know it. And then you can also use the polymerase chain reaction. Now, let us look a little bit, because Kolebu, they had a study on congenital malaria. And in their study, they realized that it was the Plasmodium falciparum that was predominant. So they checked the parasitemia. They had positive for 9 babies, and all of them, it was the Plasmodium falciparum. Now, all these babies had low parasitemia, and this has implications. They had low parasitemia, means that their parasite load were quite low. And then they realized that because of the low parasitemia, they couldn't identify most of these on the microscopy or the rapid diagnostic test. Most of these tests, they use, so in fact, they use all the 3 tests. They use the Giemsa staining, they use the rapid diagnostic test, and they use the PCR. He realized that some of them, there was no parasite on the microscopy, that's the Giemsa staining, nor did they find anything on the rapid diagnostic test. Meanwhile, they had quite a number, that's 56, were identified using the polymerase chain reaction. So then we realized that we may easily say or discount and say that, oh, FMI facility, we have never seen congenital malaria before. Maybe the reason you have not seen is the test you are using. If you are to do a PCR, you identify congenital malaria. So that's a food for thought for all of us, that maybe our test is not optimal in identifying them because usually the newborns, they have low parasitemia. They have low parasitemia. Now, this is the Giemsa staining. It will help you to identify, as I said, the thick film. It will just help you to know the number or the presence and the number of the parasites. Then we have the thin film that will help you to identify the species that you are actually dealing with. Then there's the rapid diagnosis test, which I believe that is very common now. It's like a bedside test on our wards, in our consulting rooms. You just need to get a drop of blood from the patient, and then you use your control, you use your buffer, and then when you get your 2 lines, it means that the person has malaria parasites. And with the rapid diagnostic test, remember that it is species specific. So like this one that I've projected here is for PF, meaning Plasmodium falciparum. Now, if the baby person comes in and the person has Plasmodium ovale or vivus, and you check, and you do, oh, you don't have malaria. Oh, please, it's not malaria. Oh, take some painkillers and go and rest. But you check only with the RDT for Plasmodium falciparum. There can be other forms of, although we have said that falciparum is the commonest, it doesn't stop the others from manifesting. So please always have a look at the diagnostic test, which one you are using, so that you know whether it's covering all the species or covering 1 or 2, so that you know if you have to even do a follow-up with maybe a blood film, then you know that maybe you have to do a blood film, because all that I have is for the falciparum. I hope that is clear. All right, then we have the PCR. PCR that helps us to detect the Plasmodium species. They help, and it is more sensitive, as the study showed us. It is more sensitive because of the low parasitemia in the newborn baby. It is more sensitive than the microscopy and even the RDT. All right, so how then do we manage? We have identified how we'll be able to get these babies tested. The question is, how do we manage? So the management, we have the 2 main aspects, the supportive care and the definitive management. For the supportive care, we have analgesia because they may come in with fever. You may have to transfuse if the baby is pale. Phototherapy if the baby is jaundiced. You may give supplemental oxygen if the baby is in respiratory distress, and you may have to support IV fluid, especially if the baby is unable to feed very well. So these are all supportive management for the baby with malaria. Now, for the definitive treatment, let's look at some history. As I said, today is World Malaria Day, so give it all the attention. Now, the treatment of malaria has evolved over time. And as for this one, when I say it, those of us who are as old as I am will testify to it. At first, when you have malaria, it was a headache because you're going to get injection. You are going to get injection. We had the chloroquine in the system, isn't it? So we know that malaria has evolved with time. And in fact, even before we were born and we were afraid of injections, there were a lot of things that were happening in the scientific world with the treatment of malaria. Now, quinine was the first effective treatment of malaria. Can you imagine? Quinine has been there for a very long time. It was from a bark of a tree called Cinchona tree. That is where they derived quinine from. And quinine has been very effective in the management of malaria for a long, long time. Then in the 1970s, artemisinin was rediscovered. I'm saying rediscovered because artemisinin had been there for a long time. The Chinese people were using it in their tea. they were using it to treat their malaria, but it was not accepted globally by WHO until in the 1970s. A scientist worked on it and then derived the artemisinin from the tea, so that it became a preparation, a standalone drug, because at first it looks like it had other compounds with it, and WHO was not accepting it. So the scientist now was able to get it out in its raw state, and it became artemisinin. And in fact, artemisinin is now championing the cause of malaria treatment currently, globally. That's accepted because there has been a lot of resistance to the chloroquine that we were used to. A lot of resistance have developed, and now these artemisinin-based therapies are the real ones for the treatment of malaria. Now, when it comes to neonatal malaria, usually we use artesunate, that's the IV preparation. When we come and we think that this baby has malaria, we give the IV preparation of the artesunate. Usually it's 3 milligrams per kilogram at 0, 12, and 24 hours. Now, if afterwards we need to continue, we use the artemether lumefantrine, but it's always challenging. And I believe clinicians here, you agree with me, that's always challenging because, in fact, artemether lumefantrine should be used in children above 2 years, because the smallest dosage is 120. It's always challenging, but sometimes you may have to break the tablet and all that, because now we don't have the neonatal preparations. But well, by and large, we are hoping that the pharmaceutical companies will be able to come up with the neonatal preparations appropriate for our neonates so that we can give it to them. So that is it with the treatment. When it comes to complications, now, you see, when we talk about congenital malaria, although given the definition and everything, we remember that most of it is a vertical thing, meaning that the mother has the malaria and it is being transmitted across the placenta into the fetus, and it can cause spontaneous abortion. So, as I said, malaria is not a disease condition that you should just joke around with. You shouldn't at all, because it can lead to spontaneous abortions, it can lead to stillbirth, it can lead to premature birth, it can lead to intrauterine growth restrictions and neonatal deaths. So congenital malaria is not something we need to joke with at all. It's not something we have to joke with at all. Now, let's come back to our case study. I think we have gone on and on and on and on. It's now time to relax and see our baby. So let's come back to our case study. Our 2.9 kilogram male infant who had all these. So please, anyone to give us differentials? Anyone at all? The floor is opened. Any differential diagnosis for our baby? Please. Anyone at all can help us. Oh, anyone at all? Yes, Nana, we are waiting for you. Oh, my slide moved. Anyone at all? Oh, anyone at all? Okay, so we were thinking of sepsis. I don't know whether anybody will agree with me. We were thinking of sepsis, so because this baby, you have been with us, you have dropped fever on day 3, you better spend megaly jaundice. We were thinking of sepsis. And so we started antibiotics. But after about 48 hours, no show. Still, this baby is not improving on the antibiotics that we had given to the child. So we then decided to go back to mother. At that time, mother, cesarean session, mother has now been able to come to be with the baby. So we started asking her more questions. Always important to take a very good history. That is where the whole trick is. So when we asked there about the stuff, then she started telling us that, oh, she was only able to attend antenatal clinic twice during the pregnancy. And that when they gave this intermittent preventive malaria therapy, she did not take it all because she had nausea. So she didn't take it. And then we asked her about the use of insecticide-treated nets. She said that, oh, the weather is hot. It's pregnancy, plus this hot weather, plus mosquito net. Oh, no. Oh, no, she couldn't use it. Meanwhile, where she lives is a waterlogged area and everything. She didn't use any of them. But then she also said something that she didn't experience any fever or chills during the pregnancy. So then we went ahead to test the mother and the baby for malaria parasites. And lo and behold, blood films showed that the baby had malaria parasites. And the mother also tested, and it showed that she was also positive for malaria, although she didn't have any symptoms. So there is a food for thought for all of us. Remember, we are in a malaria endemic area, and sometimes you may have malaria parasites without really having the symptoms. I mean, because you have been having this malaria over and over and over. But remember that pregnancy is an immune state. So it will reduce the immunity a little bit, and then it will cause these parasites to proliferate. So this baby was now treated for malaria. Baby was okay, became fine, and went home happily with the mother. All right. So now let's turn our attention a little bit to the prevention aspect of malaria, which is very important. In our setting here, we cannot go through this presentation without talking about prevention. Even in congenital malaria, prevention is always better than cure. Now, a study conducted by one of our people here in Ghana showed that the use of insecticide-treated nets by pregnant women accounts for 23% reduction in placenta parasitemia. So anytime mothers use insecticide-treated nets during pregnancy, that alone will lead to 23% reduction in placenta parasitemia. And then there can be indoor residual spraying, which it can be on a national scale, be on individual scale, community scale. And then there can also, and then we have this intermittent preventive therapy in pregnancy, which is very, very important because that alone accounts to 56% reduction in peripheral parasitemia in the mother. And we know that, you see, for congenital malaria, you don't usually have congenital malaria when the mother doesn't have any parasites. The mother has to have parasites. And because, as I said, see, the whole pregnancy thing, maybe malaria, but you, except yeah, now yare kakra. It's so, no, they may not pay attention. I remember that, and remember that we are in a malaria endemic area. So having malaria is not something so out of the way. But if we are able to take strictly this preventive therapy, we can reduce parasitemia in the pregnant woman by about 50%. And also combining this and the ITN alone, we reduce malaria burden a lot in the pregnant woman and invariably in the neonate. So please, I believe some of us, we go beyond just the neonatal. Some of us are midwives and all that. Please, let us emphasize this IPT and also emphasize the insecticide-treated nets. They are very important. They are not jokes. They are very, very important to ensure that the babies are safe. Now, there have been several steps to eradication. Worldwide, they adopted DDT, and that did a lot of work in the European countries, in the Americas. That helped with the eradication by killing the mosquito, that's the vectors. But then, very soon, the mosquitoes developed resistance, and very soon, DDT lost that function. The agri people took over and they were using it for all kinds, like a pesticide, for all kinds of things. So the resistance developed quite fast. Now, we have come to an era where we are in the vaccine zone. And we have developed malaria vaccine. It has been rolled out in Ghana. Thankfully, in 2019, malaria vaccine was rolled out in Ghana. Now we are piloting it in 7 regions. And we are hoping that very soon we'll be able to get it across the country. It will be incorporated in our immunization schedules so that all children are immunized. We said that children under 5 years bear about 80% of malaria cases. So we know that when we talk about malaria, when we vaccinate these newborn children under 5 years, we'll be able to curb malaria, at least severe malaria, which can lead to morbidity, long-term morbidity and death in the child. So let's all advocate when it comes to our region. Let's all be good stakeholders, advocate for people to get the malaria vaccine so that we'll be able together to eradicate malaria from our country. So thank you very much. But before I leave you, our posters, please. Oh, I'm even giving the answer. So, okay, it doesn't matter. So we know that congenital malaria is not highly prevalent in malaria endemic areas, rather prevalent, more prevalent in malaria non-endemic areas. So it is false. And we also know that congenital malaria leads to high parasitemia in neonates. No, usually it leads to low parasitemia in the newborn or in neonate. Then fever, anemia, splenomegaly are some of the common features. Yes, it can present as such. And then congenital malaria is not so easily seen on blood film staining. Rather, PCR is the one that is able to pick up a lot of congenital malaria. All right, so thank you very much. I think I'll end the presentation here and I will pause for any questions. Thank you very, very much for your audience this afternoon.
It's fine.
Thank you, Doctor.
Hello. Yeah. Good afternoon. Hello.
No.
Hello.
No, good
Hello.
afternoon.
Doctor, thank you very much for the insightful presentation. But my question is, I want to find out, in this case, concerning the congenital malaria, will it be appropriate for maybe in the NICU setting that it becomes a routine to test for malaria for every child? And if that is so, should we also treat it when it comes out positive, even if they do not show the signs and symptoms of it? Thank you.
Thank you very much for your question. I would say that we don't need to do a routine check for every baby who has congenital, who may be born or in our NICUs. Why am I saying so? Because we are in a malaria endemic area. Malaria endemic area means that, yes, there can be parasites, but these babies will also be exposed to a lot of antibodies from the mother. So even if you check and there's parasitemia, the baby may not show any symptoms. And the reason may be because the baby has got immunity to fight against the parasites. It doesn't need any treatment. So I wouldn't advocate for a universal treatment for every child or who comes to our NICU. I will not even advocate for universal testing because of the high immunity in our system here. Having said that, it's important that we have at the back of our mind that it can occur. So if you see a baby in your NICU having symptoms, you have tried with maybe your antibiotics, still there isn't much. You have to think about congenital malaria as well, or neonatal malaria for that matter. So when there are symptoms, that one, I'll advocate that you test for it, and if it's present, you treat it. Thank you very much.
Thank
Okay,
you.
hello.
Thank
Hello.
you so correct. Please, let's kindly take the questions in an orderly manner. Okay, let's kindly take the raise your hand, and then the host will mute your microphone so you can ask. So currently, Mame Frema, you can please ask your question.
Yeah, hello. Good afternoon, Dr. Okran. So as a follow-up to the question that was just asked, there was a paper I read some time ago, and it was talking about the fact that there's an overlap in terms of symptoms between neonatal sepsis and congenital or neonatal malaria. So they proposed, I've forgotten who wrote it, but they proposed that it will be good that when a baby comes with symptoms of neonatal sepsis, you actually test for malaria as well. So in my facility, it's something we do, that when the babies come, we admit them for neonatal sepsis, irrespective of the symptoms they come with, we test for malaria, and some of them turn out being positive, and we treat. So I had also wanted to ask for your take on that. Then the second question is, with what I have read in the past concerning the treatment of congenital or neonatal malaria with the artesunate injection, what I know is the 3 milligram per kg for the first 24 hours. Then you continue daily for 7 days. So it's more like you're treating for the same duration as in severe malaria, where the person can't take orals. And in your presentation, you highlighted that we don't have formulations appropriate for the newborns. But I didn't hear you talking about any extension of the treatment. So I wanted to know whether you treat for only the 0, 12, 24 hours, or you extend to the daily doses for 6 days to make a total of 7 days. So those are my 2 questions. Thank you.
Yes, boss. Can you hear me?
Hello. Thank you very much, Mami Frema. So what you said is very true about the overlap of symptoms. It's very true, because when we looked at even the clinical features that I put up, it's like sepsis. It's like, even with the case study, it's like sepsis. Here at Confanoch, we don't do universal testing for malaria. However, if in your facility you do it, then we will rather try and get data from you to see whether the malaria, neonatal malaria, is very prevalent, in which case then we have to adopt it. Yeah, it's confirmed here, we don't. But if the prevalence is very high, because I know that you're at Agogo, the center is not so small, it's a big center. So if you do it there, and you are getting higher numbers of malaria, then maybe we should adopt it and then do it here. In fact, here we don't do it unless you really have symptoms suggestive of malaria. That's when, or maybe you have treated sepsis and still we are not getting our heads with, that's when we'll think about malaria. But then if you do it routinely in your setting and you are getting high numbers, then we may have to adopt it. So I think it's something we have to really look into. That's why I was saying that maybe it is a very good forum for us to look more into it. Because we are all like, oh, as for children, they don't have malaria, as for children, meanwhile, according to the studies, there is a good prevalence of malaria among neonates. So it's something we have to look into. And then to your second question, yes. So we can use the artesunate for the first 24 hours, as you rightly said. Then there are about 2 schools of thought where we can continue with the IVs, that is the intravenous injection of the artesunate for up to 7 days in total, or we can continue with oral. But as in my presentation, I rather said that we don't really have oral preparations for the neonates. The oral preparations that we have, that's the artemether lumefantrine, is from 2 months onwards. So we don't really have. So it is always a challenge over there. So if you want to opt for oral, it's always a challenge. So we would rather go for the IVs. But I know that sometimes you're also in a corner whereby the child now looks better, wants to go home, so they prefer oral. It becomes a challenge. That's why I was saying that maybe pharmaceutical companies will come on board so that they can get us neonatal preparations, because truly it is a challenge getting oral preparations for the newborns. Well, thank you very much.
Thank you very much, Dr. Okon. I think we'll take one more question from Nkuma Isaac. Nkuma, can you please unmute your mic and then ask your question?
All right. Thank you very much. Thank you to the organizers for organizing such a program, and to Dr. we say thank you very much. I'm from the lab unit, and so I want to make a small addition and also ask some few questions. For the species we have 5 species. He made mention of 4. We have Plasmodium noresi. It's one that has latest been discovered and is part of our species that we're handling. And when doctor was talking, she made mention of needle prick as a result of contracting malaria. So I want doctor to throw more light about it. Is it when somebody is contacted with the blood, would the sac or the malaria, the sac, if I get a bite, I know that the parasite will have to go to the liver before they come back to the bloodstream. During the needle prick, how does it occur? That I want to know the duration. If I get the needle prick today, I will start experiencing the malaria symptoms today, or maybe it will go through the liver before it comes back to the bloodstream. And regarding to the fetus hemoglobin, doctor made mention that it resists the development of the mosquito parasite. I want doctor to also throw a little bit light on it. Is it because of the formation of the fetus hemoglobin, like the amino acids? Is it because of their positions for the fetus hemoglobin F? That is how come they resist the infection of the malaria parasite. Thank you.
Okay, thank you very much for your questions. I think the first one is on the Knowlesi. Yes, there's a 5th one. That's true. That's very, very true. Thank you for the addition. And I talk about the needle prick. Yes, so when a person has the malaria parasite, and the malaria parasite has gone through all the cycle and it's now in the peripheral blood, and that person, you take blood from that person, or the blood from that person gets into contact with a needle, and that needle gets into contact with another person who doesn't have any malaria infection, the malaria parasites can be transmitted to that second person who doesn't have any malaria parasites. And then the malaria, as for that one, the cycle, it will depend on the cycle where the malaria parasite is. It may go through the liver and go through everything, just like it is being infected by the mosquito bite. Or sometimes too, you can have malaria faster because at this point, the malaria parasite has gone through all the life cycle and it's now in the peripheral blood. So the person may start having the symptoms faster than the person who gets a bite and is now going to the liver and then is going through the whole life cycle. But anyway, this is quite technical. I stand to be corrected. But I know that some studies have shown that even with needle prick, you can have malaria being transmitted. And then the next thing you talk about is the fetal hemoglobin. The fetal red blood cells are able to withstand more. It just, the fetal red blood cells are quite different. The fetal hemoglobin is quite different from the adult hemoglobin in terms of its structure. So I don't know specifically what is in the structure, but I know that it's able to withstand the malaria parasites more than the adult hemoglobin. Just like the fetal hemoglobin is able to withstand sickling, so that if a child has sickle cell, if a neonate has sickle cell, the sickle cell will not manifest. It will not because of the fetal hemoglobin. In the same vein, the fetal hemoglobin is able to withstand the Plasmodium species more than the adult cells. And so that's what I know, but I don't know the real technicalities, the biochemical, that one, if I say I will be able to tell you, I'm not sure. But I know that they're able to withstand it more than the adults. Okay, thank you very much.
You are most welcome, doctor. And to add, I think is the oxygen affinity. When it comes to the formation of the fetus hemoglobin, the hemoglobin F, they have higher oxygen affinity, and as a result, it resists the development of the mosquito parasite when it gets into the baby.
Okay. Okay, thank you very much.
Thank you very much, Dr. Okwen. Please, we'll make room for one more question. Duty Emmanuel, can you please unmute your mic?
Thank you very much.
Can you please check your message? Send your message. I've sent you a private
Thank
message.
you very much. I happen to work with Tamale Teaching Hospital, and at my facility, usually for the uncomplicated malaria for neonates, we usually do suspension amodiaquine. That's 10 mils per kg for OD for 3 days. So me hearing you saying that you usually do AL, I was a little bit confused. I don't know whether that's your protocol at CAT. So I just wanted to be sure. Thank you.
Okay, thank you very much. The issue, yes, it's true. Amodiaquine, if it's available, you can use it. You can use artesunate amodiaquine. In fact, that's what we were doing over a long period of time until amodiaquine started giving problems. In fact, the amodiaquine issues were more in adults, but because of that, the pharmaceuticals have barely reduced. In fact, nowadays when you write amodiaquine, artesunate amodiaquine for a baby, it becomes very difficult for the mother to even get some to buy. Because it's no longer so much on the market. So that's the main challenge. The challenge is here in our part is availability. So if you have it available, we don't have any problem with it. It is still a good drug. The only thing is that in adults, when they were taking it, they were developing side effects of dystonia. But we never saw, in fact, the truth of the matter is that we never saw any of such dystonic episodes in the neonate. So for the neonates, we were happy to use amodiaquine. Just that. Now, I think because of that feedback, the pharmaceutical companies also stopped bringing a lot of the artesunate amlodipine on the market. So now our issue is availability. We don't have it available here. I mean, you may find one, but it becomes very difficult for the mother to even get some to buy. And it's not stocked in the hospital as well. So that's the main reason. It's not that it cannot be used. It can be used if it's available. Thank you very much.
Thank you so much, boss. Dr. Kwan, can you please make Adamu Barikisu a co-host?
Okay, let me check how I'll be able to do that.
When you go the name, just click on the name, and then co-host.
Okay. Let me try and do that. The thing is that I haven't found her yet.
Please, if anyone has a question, you can please type in the chat box, and our speaker will attend to it during the Q&A after the second speaker also presents. So she's Adamu Barikisu.
Okay.
Hello, Doc. So you click on the Barikisu name, you see more there. Then you click on make co-host.
I can't find the name.
You can
Right
set
up. So participants, when you go to the participants, you see the name there. No, please, have you seen it?
No, not yet. I've seen Hope Exchange anyway.
You can make Hope Exchange a co-host too.
Let me try and do it. In that one too, I've lost it. Okay, let me see. It's still difficult for me because I can't find the name. Okay, let me see.
Doc, you can search in the box, Barikisu.
Okay, let me search. Yes, okay, now I'll find.
Okay, they
I
make
should yes. All right, so I've done that.
Okay, thank you.
Thank you very much.
Thank you so much, Dr. Okran, for such an insightful presentation. I think going forward, we'll have a different approach to malaria in the newborn. Thank you so much. We have quite a number of questions in the chat box. Hopefully, after our second speaker, we'll make time for more questions. Thank you so much. So we're now going to take a presentation on interpreting the vital signs in the newborn. Interpreting the vital signs in the newborn. And we are privileged to have Mrs. Barakiso Adamunyani, a neonatal nurse, an experienced one, of course, who happens to be in charge for the NICU at Hope Exchange. Mr. Barakiso, can you please take over?
Good afternoon once again. I hope you can see my slide. I'm so sorry for the earlier interruption. Our time is fast spent, so I'll just do a quick review of the vital signs of the newborn. This is just a refresher topic that we are having. So there's the outline of the presentations. So as said earlier on, vital signs can also be called cardinal signs. They are the indicators that are being used to check or monitor the functions of the baby's body. And it differs with the age, the gender, the time, medication, and environment. The environment, whether cold or hot, warm weather, will also determine the vitals of the newborn. And we know that vital signs are important indicators of the baby's overall health being. So one may ask, why do we even take vital signs? We take vital signs so that we can detect any changes in the baby's normal body function, and also to determine the response to treatment, whether the baby is improving or desaturating. The vital signs is the only thing that can give us a clear picture of what is happening.
Okay.
Come again.
See, the slides are not moving.
They are not moving again.
Yes.
Please, are they moving now?
We can still see the very first page, knowing the vital signs of the neonate.
Wow.
Yes. Now it's moving now.
It's moving. Okay. Thank you very much.
You're welcome.
Okay. So I'm done with the definition, the reason why we take vital signs. So these are some of the typically monitored vital signs in the newborn. We have the respirations, the heart rate, the temperature, the oxygen saturation, blood pressure, random blood sugar, the weight, length, head circumference, and other. So it is in, I've arranged it in vertical order. So first you check the respiration of the newborn. And then you go to the heart rate, the temperatures, and the others follow. You don't have to prick the baby. You take the blood sugar before you go back to count the respirations, do the heart rate and other things. As those interruptions can give us a false interpretation of the respiration. As we go along, we'll understand more. So this the vital signs of the newborn. This is the normal range. Temperature 36.5 to 37.5. We would want to keep the neonate vital sign within this range. The pulse rate is a little bit controversial. The 120 to 160 beats per minute, but we are used to the 100 to 160 beats per minute. Respiration is 40 to 60 breaths per minute. Blood pressure 60 over 40, and oxygen saturation 95 to 100%. I hope my slides are visible.
They are.
Okay, good.
Yes.
All right, thank you very much. So, how do we assess a baby's respiratory rate? We know that unlike adults, where you can count the respiration for 30 seconds and multiply by 2, in neonate or in the newborn, our aim is to count the respiratory rate for a full 1 minute. So where we don't do anything in seconds and multiply it, we just need the actual respiration rate of the baby. And we know that babies do have irregular breathing, and they have some periodic breathing. They can breathe and stop for a second. That's why our aim is to count it within a full minute, not the ones we do in the adult respiratory counting. So breathing rate indicates how hard the baby is working to inhale oxygen. Okay. So how do we assess it? You can put your abdomen softly, your hand on the baby's abdomen softly, or the chest. So you count each rise of the abdomen as a single breath. Please, let's note that some people count the rise and the fall, but that's not how we do it. It's just the rise of the abdomen, or probably only the fall of it, which we another way around. And I also came across that one can put alternatively position the hand a few inches from the baby's nostrils and count every exhalation from the baby's nose as a single breath. But I also ask myself, when you're in gloves, how can you do this? So I prefer we count the rise and fall of the rise of the abdomen or the chest. And we know that in breathing, the baby's breathing, the chest and the abdomen should synchronize. It shouldn't be in a seesaw manner. The chest shouldn't rise and the abdomen rather, it should be synchronized. We know babies are abdominal breathers. So this is how the pattern should be. So in assessing the respiration of the newborn too, you need to monitor the rate, the effort, the breath sounds, the sign of distress, whether tachypneic. You should also notice the nasal flaring, sternal injury, rib retraction, grunting, etc. This will also be very, very important to write while when referring a baby with an abnormal breathing rate. So abnormal means less than 40 or greater than 60, and most specifically after 80 breaths per minute. So we go to the heart rate. When we say the heart rate is the number of times the baby's heartbeat. And we learned that it's 100 to 60 breaths, 100 to 160 beats per minute. Babies have faster heartbeats. So we should remember that the heart rate, the respiratory rate, and the blood pressure are closely linked, in the sense that if a baby doesn't get enough oxygen, their heart rate and respiratory rate will speed up in an attempt to get more oxygen. So these three parameters are closely linked. Sometimes referrals come and you see a respiratory rate of 196 and a higher respiratory rate, and the heart rate will be around 40, 60 breaths per minute. So my little knowledge that I've learned that the heart rate and the respiratory and the blood pressure are closely linked. Fine, I can't justify that in all cases it should move in the upward or downward manner. But we shouldn't base our last option on the monitors. So there's a video that we are about to watch that will show us how to count the respiratory rate in the infant, the heart rate of the infant. Please kindly let me know if the sound.
Hey everyone, this is Sarah with RegisterNurseRN.com, and in this video I want to demonstrate how to assess the heart rate in an infant, and of course perform hand hygiene before beginning. To count the heart rate, you want to make sure that you're using the appropriate size diaphragm and bell, and we have an infant here, so we're using an infant size. And for an infant who is less than a month, a normal heart rate is about 100 to 190 beats per minute. And this can vary if the infant is crying or if they're sleeping. Now, if the infant is over 1 month, that heart rate goes down a little bit, the normal ranges, and it's about 90 to 180 beats per minute. So to count the heart rate, what we're going to do is we're going to use the apical pulse.
You can see the video.
Pulse, like how we do in adults. So to find the apical pulse, what you want to do is you want to find the fourth intercostal space. Now, in an adult, remember, it was the fifth intercostal space at the midclavicular line. But for an infant, it's at the fourth intercostal space, lateral to the midclavicular line.
Yeah, Dr. Wadi.
Please, we can't see the video.
Hey everyone, this is Sarah with RegisterNurseRN.com, and in this video, I want to demonstrate.
Please, can you see it now?
No, please.
Oh. Please kindly hold on. I don't know why I'm encountering this problem.
How to assess the heart rate.
Yeah, we can see now.
Hey everyone, this is Sarah with RegisterNurseRN.com, and in this video, I want to demonstrate how to assess the heart rate in an infant, and of course, perform hand hygiene before beginning. To count the heart rate, you want to make sure that you're using the appropriate size diaphragm and bell, and we have an infant here, so we're using an infant size. And for an infant who is less than a month, a normal heart rate is about 100 to 190 beats per minute. And this can vary if the infant is crying or if they're sleeping. Now, if the infant is over 1 month, that heart rate goes down a little bit, the normal ranges, and it's about 90 to 180 beats per minute. So to count the heart rate, what we're going to do is we're going to use the apical pulse. We're not going to use the radial pulse like how we do in adults. So to find the apical pulse, what you want to do is you want to find the fourth intercostal space. Now, in an adult, remember, it was the fifth intercostal space at the midclavicular line. But for an infant, it's at the fourth intercostal space, lateral to the midclavicular line. So you want to find the clavicle, and then we have the breastbone. And we're going to go down and we're going to fill in between those little ribs. And we're going to go to the fourth space. So there's 1, 2, 3, 4. And then we're going to just go lateral to the midclavicular line. So we're going to go about right here. And this is about where the apical pulse is on our infant. And we're going to place our stethoscope there and we're going to listen for 1 full minute. Now, an infant's heart rate can have sinus arrhythmia where it's irregular because their heart rate can be affected with the respirations, where their heart rate will actually speed up and slow down with respiration. So that's where you want to count for 1 full minute. Now, counting an infant's heart rate can be difficult because it is fast. And one thing that I have found that definitely helps me is I find that heart rate and then I tap my finger along with that heart rate and count. And our infant's heart rate here is about 142.
Okay, so that wraps up this video on how to assess the heart rate in an infant. And be sure to check out the other videos in this pediatric series.
Thank you. So we will continue with the monitoring of the temperature of the newborn. So mostly we prefer the armpit temperature. So we use a digital thermometer. Then you place the thermometer in the armpit, the baby's armpit, making sure that it touches not the skin. It touches the skin, not the clothing. You close the baby's arm over the thermometer, holding their elbow against their body. So you wait until the thermometer beeps and then check the digital display for the temperature reading. We learned that the normal temperature is 36.5 to 37.5. We want to keep the baby's temperature within such range. So abnormal temperatures are 35.5 to 36.4 degrees Celsius. And the danger signs are above 37.5 and less than 35.5 degrees Celsius. So in the process of referring a baby who is hypothermic, you want to ensure that the baby do a skin to skin. That's when the mother is stable and the mother can join the baby during the referral. Also, you can talk to the ambulance team to also regulate the temperature of their air conditions so that the baby can also pick up. You need to dress the baby with a cap, socks, and mask. You need to wrap the baby very well. You take out all wet clothing, all wet diapers, and ensure that the baby's temperature will be improved. And research has also shown that rapid rewarming of babies can lead to apneic episodes and other things. So you wouldn't be in a haste to increase the warmer to a higher percentage if you want to improve the baby's temperature. So the oxygen saturation tool of a unit, assessing it. 1, you have to apply the probe to the baby, ensuring that the light source is directly opposite the photo detector and the probe fills snugly without any gaps between it and the skin. So you don't want to apply the probe so tightly that it will interrupt blood flow to or from that side, the site where you are taking the saturation recording. And I think I went through some readings and I noticed that they prefer the right hand or the right side of the baby because I learned saturation is perfusion is much higher on that side of the baby. So if you apply the pulse oximeter, the probe very tight, it may impair circumferential retraction or arterial flow or venous return. And this venous congestion may lead to venous pulsations, and in the end, you get a false reading. So when we're applying the oxygen probe, we need to be careful of this false constriction. With babies less than 37 weeks, your aim is to keep the saturation at 90 to 95%. And with 10 babies, the aim is to keep the saturations above 95%. Hello?
Yeah, you are ahead.
The slides are not moving. Hello?
They were moving, please. They were.
Okay, all right. Thank you very much. We are far behind time. That's why I'm making everything so concise that we can go back to our normal duties. Some were also at work and So in conclusion, babies are not little adults, and it is true when it comes to their vital signs. So healthcare providers must understand the various physiologic and the pathological process affecting these sets of measurements and their proper presentations. So these are the references, and thank you very much. Please, any questions? I know there's a quick one because the time is fast spent.
Thank you so much, Mr. Barkisu. Please, want to make room for questions. So if anybody has a question, you can please type in the chat box or mute your mic.
Thank you, Doc. Please, can we get the slides? Some of us joined it.
Come again, please.
You can visit the link for the video. There's the link there. Yeah, or YouTube.
Oh, okay. So we have the link to the YouTube in the chat box.
YouTube, the channel name is.
So the link is in the chat box.
Oh, okay.
Yes. So because I think there's a question in the chat box that's saying that. So does it mean a temperature of 37.5 is normal?
Your aim is to, I think some ranges prefer, describe 37.5 as a higher temperature. Okay. But there's the range that you need to keep the baby within. So it can be, it's 36.5 to probably 37 point, because during the slides, let me check the danger signs of the temperature.
Hey, everybody.
Hello.
Yeah. So if you can, the last part of this slide, the danger signs is greater than 37.5 and less than 35.5 degrees Celsius.
Right. So 37.5 is more of a borderline.
Other suggestions too are also welcome.
Hello.
BK, if I may just come in here. So in essential care for every baby, we normally have been teaching that 37.5 and above will be your danger sign. So the normal will be up to 37.4. So 37.4 will be within your normal. But like you rightly said, in some other documents, they have used above 37.5 as a fever. But for Ghana standards, we have been using 37.4 as your cutoff. So 37.5 and above will be a danger sign. Thank you.
Thank you, boss.
Thank you, boss. Miss Mavis, Kuku, can you please unmute your mic and ask your question?
Thank you very much for the opportunity, Barikisu. That's a very great presentation. Please, I would like to say that Essential Care has updated their logistics, their data as of 2023. So now 37.5 is being considered as a normal temperature range, and that's what is being used now. So now 37.5, it's normal for the newborn. So it's between 36.5 to 36.5 to 37.5 instead of previously 37.4. And now at first 37.5 and above was considered the danger sign, which required referral in the periphery. But now to refer, you need to get a temperature of 38 degrees and above. So that's the current data. Thank you.
Thank you very much for the great submission. I hope you are also learning a lot.
Is there any more questions?
Most of them have been typed in the chat box.
Sorry, please, we didn't get you.
more questions in the chat, but I type if you can go through them as well.
So for Irene Jim, please, Irene, do neonates have FBS? What is the normal range for RBS? Mr. BK, can you please speak to it?
RBS, I know less than 2.5 is hypoglycemia, right? So you want to keep the RBS within 2.5 to 4.5. No. With the RBS, I didn't capture it for that one day. I didn't capture it. I took only the temperature, the respirations, and of course, at time was expensive. I had to take some of the slides out. But any submission is also welcome.
Please, any more questions? I think that's no, maybe it's already spoken. So there's any suggestions on the use of P-alaxin syrup in newborns? I'm sure this is for the malaria. Please, Mr. F.I. Hello.
Hello. Hello. Please.
Yes, please. Dr. Kwan.
Yes, so please, as for the malaria preparations, there are a lot of them. So if you have one and you check the label and can be used in units, you can use them. We just have to pay attention to the dosing because usually most of the malaria preparations are for older children. So you just have to be a little bit more careful with the dosing. But apart from that, there isn't any malaria treatment that you cannot use for neonates or you can use for neonates. The only issue we had was with the dose. So that's all that I was saying. So we can use any of them. Just to make sure that the dosing is right for the neonates. That's all.
All right, thank you so much. Dr. Kwan, please, there's another question that says, please, how do you prevent malaria in a G6PD expectant mothers who cannot take the intermittent preventive therapy, the SP?
Yes, so with GSSPD mothers is always very challenging because this our malaria for the IPT. We have the malaria, the malaria treatment, which has sulfur in it. So for them, they cannot take it because they may react to the medication. For these ones, we can only treat. So for them, we will ask them to use insecticide treated net on all other prevention, that is environmental prevention. They cannot take the medication. And then if they have malaria, we treat the malaria promptly. So that's all that I can say. We cannot give them the medication because of the sulfur in it. Thank you.
No. So, all right, thank you so much, both. I think we'll take two more questions. But there's a question that says, please, do we have to give anti-malaria post-blood transfusion? And how long do we treat since the tab almost AA is unavailable currently?
Well, thank you very much. For blood transfusions, we'll advocate that before you transfuse any baby, please check the blood because usually we use adult blood. So that one, if there's parasitemia, it will be easily picked up. So check the blood with your RDT first. And if it is positive, then you don't give it. Or if it's positive, then you know that when you give it, you have to treat the child for malaria. And if it's negative, then after the transfusion, you don't need to treat the child for malaria. So our main advocate is that check the blood to be transfused first. If it is positive, then you need to treat for malaria. If it is negative, you don't need to. Thank you very much.
Thank you very much. I think there's a few questions here. So, boss, there's a question that says, what number of parasites will prompt for IV use in neonates?
Please, in neonates, as we said, usually they have low parasitemia. In fact, for neonates, when they have malaria, we treat it all like severe malaria. So for all of them, we advocate for IV therapy for all of them. But having said that, sometimes you may just have an incidental find where the child is very well, the mother obviously will not stay in the hospital. That is where you may opt for oral treatment. But let's say the child comes with signs of sepsis and those things, and then you want to treat that one, you treat like severe malaria. But if it's like an incidental finding, a well baby, you incidentally find malaria parasite, obviously that mother will not want to stay in the hospital. That one you treat with oral. So that one, because all of them have low parasitemia, we don't have any cutoff parasite number for us to use IV or oral. But as I said, if the baby is very stable, no clinical feature, baby is very well, it's just an incidental finding. That one, you can go for your orals. If the baby is in hospital and is receiving medication, then go for IV. Treat like severe malaria. Thank you very much.
Thank you very much, Dr. Kwan. Thank you so much for such a wonderful presentation. I think at this juncture, I wouldn't take any more questions. We would go straight to our next item. Please, can you all see my screen? Hello?
Yes, we can see.
Yeah, we can see it.
Okay. So we just want to do a refresher course on the relevant information we need to put on the referral form. So this is a sample of our referral form. It might vary from facility to the facility. So we have, for this one, we have the part for the demographics, the name of the patients, where we're referring to. But before we go to the form, we just want to remind ourselves that we've been doing very well with the referrals that have been coming to Hope Exchange. Some facilities call before they bring the babies around, others to just do walking. But we humbly ask that going forward, we should please call before we refer any case, because we have cases coming all over from the Kumasi metropolis. So sometimes our NICUs get choked. So if you do a walk-in, we find ourselves in a tight situation. But we humbly ask that you can just give us a call and then we'll tell you what to do from there. So please do call us. Do call before you bring the referrals. So like every referral case, it should be accompanied by a referral form, and the demographics should be clearly stated, and also a clinical summary. So with the challenges we're having these days is that the summaries that are given or the presentation that is done on phone varies from what's on the referral form. So we humbly ask that let's please key in the important details. So whoever is making the call should be because if you communicate one thing and then you receive another, you realize that the information tends to contradict. And most of the cases that are referred are emergency. Please do well to give us the concise and the right summaries with regards to the referral case. And also, it should be accompanied by the ANC book for the mother and the details during the delivery, the abgas and all should correspond, because sometimes you realize that most facilities tend to fill the book when they're referring the case. So they just key in any details. And then when we later call, you realize that the results or the answers they are given does not correspond with what's in the ANC book. So please, let's do well to communicate the right details to the referring facility. So the lab results that was done could at least be inputted on the referral form, the treatment that has been given so far, and a clear picture of the vitals as of the time of referring, so that when we receive the neonate or the baby, we can know where to continue from. Thank you very much. So at this juncture, I would invite Dr. Modesta in to please give us...
Sorry, David, before you invite Modesta, could I just say something about the referral form?
Yes, boss.
Okay, so once again, thank you all for working with us, those who refer to us and those who we refer to, like Dr. Kia at Confanoche. Thanks for always being receptive to us and always giving us feedback also. Regarding the referral form, just one thing that I want to add. As David has said, every single piece of information requested there has its importance, and it helps us know how to manage the child and how to plan for the child. Sometimes you may have done a lot which exceeds the space available on the form. Just add another sheet of paper. It can be a plain A4 sheet or whatever. Just add it to the referral form and then write out whatever else has been done for the baby, so that it helps us in our management. Let's say maybe you've done some x-rays, but you're not able to print it out. At least let us know what you saw. You did some labs, but because of LIMS and all the softwares we are using, you are unable to print them out. Just at least state the relevant pieces of information for us on those sheets, so that then we are well able to manage this child. There's a kid who's on admission, a baby, who came in with very bad abgas, bad respiratory distress, but there's no note in the referral form about whether or not there was meconium aspiration, how the LICOR was. So it's difficult for us to be able to tell whether there was meconium aspiration, whether we need to add certain treatments or not. It makes it difficult. And sometimes the numbers written on, I don't want to say our ghost numbers or numbers of, of our ghost numbers. So sometimes getting back is difficult. So please add the necessary information, add a sheet of paper, add any relevant information, labs, x-rays, etc., that you think may help us be able to manage the patients. And if you are having any challenges with us as a facility regarding receiving your referrals or getting feedback or anything like that, kindly let us know. David, can you put a NICU number on the chat so that they'll be able to get this number and they'll be able to call us and give us feedback and give us information about any challenges they are having, and also use the number for referrals. Thank you.
Thank you very much, Dr. Adama. Thank you so much. I think this meeting would have been complete without you adding your voice. So thank you so much. I believe we've all learned a lot from today's discussion and we'll be able to apply it to our practice going forward. Please, I've posted the NICU number for Hope Exchange in the chat box. So let's all kindly save it. and then do phone in when you're referring the cases. At this juncture, we invite my very own boss, Dr. Modesta, to please give us the vote of thanks.
Good day, everyone. First of all, we thank the Almighty God for such a successful discussion. We thank our seasoned speakers, Dr. Ekefriye, Mrs. Barkis Sunyani, for such insightful presentation. To our cherished participants, we say thank you for making time out of your busy schedules to join. I believe we've picked one or two things from this session that will help us appropriately manage our units henceforth. We appreciate your presence and time and hope to see you again in our next conference. Thank you and have a good day.
So thank you all for joining. And this is the end of our conference. Thank you all once again. God bless you.
Dr.
Yes, please.
Please let me take the number here. Some people wants to write it. The NICU number.
Oh, okay. It's in the chat.
050 145 5111 050 145 5111. Thank you.
So, can you please take it again? Yes, please.
Good afternoon. Please, I joined in late, but I'm very interested in the malaria in unit. Please, can it be shared? The presentation slides. I don't know. Can it be shared to us?
Dr. Okran, I think we would communicate with her, and then if we happen to get it, we would forward it to you.
Hello, please come again.
First, we wanted to know if you could share your slides.
Oh, okay. No problem.
Okay. So please, you forward it to us, and then we'll forward it to the various facilities.
All right, I'll do that.
Okay. Thank you so much, and thank you all for joining.
Dr. Boache, please, I am in Upper West.
Yes. So you can just send your number in the chat box.
Okay.
And then I'll
forward
it.
Okay. All right. Thank you so much.
You're welcome.
Dr. Abuaje, the way she's so concerned about it, I beg you, please let her have it. I think she's been having a lot of cases, so please make sure you let her have it. I beg you.
Yes, please. I'm waiting.
Sorry, please, who is this?
This is Evelyn. Evelyn Kunedi. I'm in Babli Polyclinic, Upper West.
You're in which facility?
Babli Polyclinic is in Upper
Babli
West.
Polyclinic. Okay.
Yes.
All right. Please, they will let you have it.
Okay. Thank you so much.
Okay.